It's my pleasure to welcome you here. In this session, we try to begin on time, even though the technical shut down our microphone initially. So without further delay, I would first present my co-chair, Jacques Duranteau from Paris, and then I will invite Jacques Creter, the local one, to present on tissue perfusion indices.
Thank you very much, Daniel. So I go rapidly on my talk. Will be how to better assess peripheral perfusion. So I have no conflict of interest to declare for this talk. When we speak about exploring peripheral perfusion, we speak, in fact, for skin on musculovascular beds. And you can ask me, what is the clinical significance of monitoring perfusion of these non-vital organs like muscle, skin, who are not crucial for immediate survival? The question is simple. This is basic physiology. Peripheral perfusion is among the first to deteriorate in circulatory shock and the last to be restored after resuscitation. And it has been well demonstrated even in healthy volunteers. If you impose to healthy volunteers a lower body negative pressure and you use the peripheral perfusion index, the PPI, to assess the peripheral perfusion, you can see in red that the peripheral perfusion will decrease well before any increase in heart rate or any decrease in blood pressure. You can do the same experiment also in healthy volunteers using near-infrared spectroscopy technology, and you can say well before the decrease in mean arterial pressure in those healthy volunteers submitted to lower body negative pressure, the tissue saturation of oxygen assessed by an infrared spectroscopy decrease well before any decrease in blood pressure. So exploring peripheral perfusion could help the clinician to detect occult tissue hyperperfusion in critically ill patients. There are a lot of techniques to assess peripheral perfusion, and to summarize, in fact, all those techniques have shown that the alteration of peripheral perfusion is associated with a worse outcome, and the degree of alteration is well correlated to the degree of the circulatory shock. You can use, for example, the modeling score here, and this is easy to use, and clearly this modeling score, the value of the score is correlated to the SOFA score and inversely correlated to the arterial blood lactate, meaning that there is a clear correlation between the degree of peripheral perfusion and the severity of the disease. Those scores can predict mortality, and very rapid mortality. As you know, if the score is high, the chance to die is unfortunately very high. You can use also capillary refill time, which is easy to use, and some groups have developed automatic technology to measure the RCT using a simple pulse oximeter and with an automatic pressure which is induced on the fingertip of the index, and you can have automatically the RCT measure. And again here there is association between deterioration of the capillary refill time and here the 2-week survival. You can assess also peripheral perfusion using near-infrared spectroscopy, and this study performed by the group of Jan Bakker showed that if the STO2, which is the tissue oxygen saturation, remains low during a resuscitation procedure, the chance to die is higher. This is the same technology, but not applied on the thenar eminence, but on the knee, and as you can see, if the STO2 remains low, the chance to die also is very high. And this is another study who compare different techniques to assess peripheral perfusion. It seems that modeling score, knee STO2 seems to be doing better. There are better prognostic technique to predict the 40 days survival than, for example, the SCVO2. What we have developed since the last 2 or 3 years is to try to assess the peripheral perfusion using a laser Doppler. So we assess fingertip skin blood flow on the index of the patient. And this kind of laser Doppler technique can also warm the skin. The idea behind this, if you warm the skin, you induce a vasodilation, and our hypothesis was that in critically ill patients, especially in patients with circulatory shock, this increase in flow induced by warming the skin can be blunted. So first of all, we compare healthy volunteers to patients in shock with different variables provided by the laser Doppler. As you can see here, the SBF, which is the skin blood flow, is, let's say, 10 times higher in healthy volunteers than in patients in shock. When we measure the skin blood flow at 37 degrees of temperature, again, in healthy volunteers, you have a huge increase in the skin blood flow. And what is also interesting to trying to standardize the thermal challenge, let's say, we calculate also the delta, so the change in skin blood flow against the change in temperature from basal temperature to 37 degrees. And again, here, as you can see, the magnitude of this change is very, very low in patient shock compared to healthy volunteers. So we compare also the skin blood flow at the admission of ICU to other parameters of the severity of the disease. As you can see, there is a nice correlation between the skin blood flow, and the SOFA score at baseline or lactate concentration at baseline. And if you divide patients in circulatory shock between those who will survive and not survive, the survivors are in black, and you can see that the skin blood flow increased day by day. They didn't reach the normal value of healthy volunteers, but in non-survived, the skin blood flow remained very low. And it was the same results for the ratio, the delta SBF to delta temperature. So here we were able to show that clearly, comparing to SCVO2 or lactate, the variables derived from this technique were better prognostic for death than SCVO2 or lactate. But that's prognostication here. Could we apply this in the clinical setting? The idea here was to try to study the effect of a fluid challenge, fluid bolus on fingertip skin blood flow. We all know that we need sometimes to give fluid to patients. We know that roughly 50% of those patients will respond in terms of an increase in cardiac index. And in some of those patients, the increase in oxygen delivery will result in an increase in VO2. And in fact, this is this group that we need to identify, patients who will respond to a fluid challenge, but who will respond in terms of DO2, but also probably in terms of VO2. And as you can see here, when we measure the skin blood flow during this fluid challenge, you can see that the skin blood flow, so the delta skin blood flow against the delta temperature, increased only in VO2 responder. And at baseline, this ratio was lower in VO2 responder than in VO2 non-responder. You can see here the magnitude of the change of skin blood flow during the fluid challenge. And again, this magnitude was higher in VO2 responder compared to VO2 non-responder. And if you want to predict the increase in VO2 in patient will increase the DO2 during a fluid challenge, the best way to do it, let's say, is probably the parameters derived from this technique, again, lactate or SCVO2. Another thing can be interesting also is to see the effect of fluid removal on peripheral perfusion, always using the same technique. We all know that when a patient is stabilized, we have to go to what we call de-escalation. And de-escalation means weaning of the vasoactive agent and trying to achieve a negative fluid balance. We have this kind of problem every day in the ICU. We want to retrieve fluid from the patient by using, for example, the CVHD, and sometimes we stop this because we see the lactate increase, we see the SVO2 go down, or we have to increase the dose of vasopressor. So our idea was, by monitoring continuously the skin blood flow, we can probably predict earlier the occurrence of tissue hypoxia. And this is a simple study here. As you can see, the doctor in charge, the physician in charge of the patient decide to start CVVH with removal of fluids, and each hour we assess skin blood flow, and also with, let's say, skin blood flow, but also the thermal challenge. And so tissue hypoperfusion was defined, because we need to define tissue hypoperfusion, by an increase in lactate concentration of more than 10%. And as you can see here, in white, this is skin blood flow in patient in which there was no increase in lactate at 6 hours. So there is a decrease in skin blood flow, but clearly not comparable to the skin blood flow that you can see in patient in which at 6 hours, so after 6 hour fluid removal, you have an increase in lactate concentration. Here you can see that during the first hour, so the delta of the SBF, the difference in skin blood flow at baseline and after 1 hour fluid removal. So there is a huge increase in in skin blood flow in patients who will develop tissue hypoperfusion defined by an increase in lactate blood concentration after 6 hours. So clearly this technique can't identify early, just after 1 hour, who will develop tissue hypoperfusion after 6 hours of fluid removal induced by CVVH. And again, the ROC curve shows you here the same results with the baseline SBF or the delta SBF measure at 1 hour of fluid removal. So you can say also, is there any evidence to use peripheral perfusion to guide therapy? I'm sure you are all aware of this study, the Andromeda shock study. They compare the resuscitation guide by normalizing CRT and the other group normalizing or decreasing lactate levels. It's a pity because if I wanted to construct this kind of study, I would add capillary refill time to, let's say, standard resuscitation, including lactate. But this study is supposed to be negative, but as you can see, there was a difference of 10% between the lactate group and the peripheral perfusion in favor of the peripheral perfusion. So this is a decrease of 10% of mortality with a p-value of 0.06. So you can say this is negative, but it's always positive with the evolution of the SOFA score who go in the same way with an improvement of organ dysfunction. You have to know that those results have been reanalyzed using a Bayesian approach and clearly using this more pragmatic, let's say, approach, statistical approach. They conclude that peripheral perfusion resuscitation may result in a lower mortality and faster resolution of organ dysfunction when compared to the other approach, the lactate target resuscitation strategy. So in conclusion, peripheral perfusion is among the first to deteriorate in shock state and the last to be restored after resuscitation. So we can use this, let's say, physiological rationale to use this technology to try to identify earlier any hemodynamic deterioration. Techniques assessing peripheral perfusion are non-invasive, reproducible, and relatively easy to perform. Alteration in peripheral perfusion, as I show you, is associated with a bad outcome, and of course the impact of peripheral perfusion targeted resuscitation on survival of critically ill patients needs yet to be investigated. Thank you very much for your attention.
Thank you very much, Jacques. You illustrated your talks by different indices, so each seems to be of value. But which one should we use at the end?
That's a good question, Daniel. So I didn't have time to discuss about that, but of course, for prognostication, probably all those techniques are okay. The fact is that we compare PPI to CRT and to the skin laser Doppler. First of all, the most reliable approach is the laser Doppler. And you can ask me, why do we use laser Doppler on the fingertip and not in another part of the body, because it works in another part of the body. But clearly, if you want to differentiate patient who will survive and not survive, and if you want to correlate those signals to the severity of the disease, it works only at the fingertip and not, on the arm and other place. And of course, you just have to apply. You have a machine who gives you a number. It's not the same, and I see Jan Bakker coming, we defend the CRT, but sometimes, it's a little more complicated, subject to a sort of variability to use CRT. But we are not so far to have it automatically, because it's clearly easy to do. You use a pulse oximetry and an automatic pressure on the fingertip, and you can have the results.
Jacques, just another question, because very nice result. And did you test this device during passive leg raising?
I'm sorry, no.
No, just to know if it's sensitive,
the
degree
I fully
of
agree.
sensitivity.
Yes, because I must be honest, when you see the data on the effect of fluid challenge to detect an increase in VO2, you need to do the fluid challenge. So you already have given, let's say, a bolus of fluid. Of course, if the patient is okay in the criteria to do a passive leg raising, I think that we can extrapolate the results here without giving any fluid. But I'm not sure that this is so easy to do that with, you have to measure the SFVO2, calculate the VO2, and blah, 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 in very rapid intervention.
Thanks a lot.
If you compare it to the prediction of fluids, it's a little bit different from prediction to the patients who increase their VO2, because indeed, for prediction of the VO2, you need to give fluids. That's the point.
Absolutely right. But if you, after one bolus of fluid, if you see that VO2 didn't increase, but you can stop, even if the patient was responsive to fluid.
For sure.
Thanks a lot. We have to move on. And it's my pleasure to introduce Jean-Louis Teboul. And Jean-Louis will talk about assessment of fluid responsiveness.
Thank you very much. Good afternoon, everyone. Again, it's a pleasure to be here in a face-to-face meeting. Thank you, Jean-Louis Vincent, for the invitation. My conflicts of interest are on this slide. First, I would like to define very briefly the concept of fluid responsiveness. It is defined as the capacity of the heart to significantly increase its stroke volume or its cardiac output in response to a volume challenge. And I like to show this Frank Starling mechanism with stroke volume on the y-axis and ventricular preload on the x-axis. You know the curve is not linear, but curvilinear. And I like to define preload responsiveness as a condition where if you increase preload, for example, by giving fluids, you can also increase the stroke volume. And preload unresponsiveness, you increase preload, but you do not increase the stroke volume. And of course, fluid infusion will increase the left ventricular stroke volume if only if both ventricles are preload responsive. And therefore, I can say that fluid responsiveness, which is a clinical concept, is equivalent to biventricular preload responsiveness. Okay, having said that, the question is, why do we frequently need to assess fluid responsiveness after initial resuscitation in patients with shock? For different reasons. The first one is that not all patients, even in shock, are fluid responsive. I would like to illustrate this by this old paper we did with Frédéric Michard in the past, and among around 400 patients, only 52% of these patients increased their cardiac output in response to fluid administration. So therefore, again, not all patients are fluid responsive in the ICU. The second reason is that fluid responsiveness is a dynamic phenomenon. And Jacques Retter already showed the Andromeda study, Andromeda shock study, by Glenn Hernandez and others. And what is interesting in this study is the assessment, that the assessment of fluid responsiveness was made in 82% of patients. And among these 82% of patients, 70% were fluid responsive at H0, at baseline. Of course, they already received the fluid before inclusion. This is why 70%. But what was interesting is after 1 hour, this percentage decreased. After 2 hours, after 4 hours, 6 and 8 hours, only 4% were still fluid responsive. So it's not a static phenomenon, it's a dynamic phenomenon over time. The third reason why it is important to assess fluid responsiveness is because fluid infusion could be risky in non-responders, the risk of pulmonary edema, etc. And also, fluid overload is, in general, is harmful. And for example, I know you know this study by Jean-Louis Vincent and co-workers, the SOAP study, which was one of the first studies showing that a positive cumulative fluid balance is an independent factor associated with mortality, and this was replicated by many other studies. And the fifth reason is that the use of fluid responsiveness test could be associated with improved outcome. And I like to refer to this recent study by the group of Arnaldo Dubin and co-workers from Argentina. It is a cohort study, multi-center prospective cohort study. And what was interesting is that the use of dynamic tests of fluid responsiveness was independently associated with a better outcome, with survival, which is interesting to know. Okay, now how should we assess fluid responsiveness after the initial resuscitation? It is recommended now by many international societies like the Surviving Sepsis campaign, like the European Society of Intensive Medicine, etc., to use dynamic over static variables to predict fluid responsiveness. But what is a dynamic variable? If I refer again to this Frank-Starling mechanism, I can say that there is not only one single Frank-Starling curve, but a family of curves between a normal heart and a failing heart. And therefore, what could be interesting is to quantify the slope of the Frank-Starling curve at the time you decide to give a treatment to your patient, because your patient is not stable. And for this, we can have different categories of indices. We can have heart-lung interaction indices in patients who receive mechanical ventilation only, and passive lung test in every patient. What about heart-lung interaction indices? Very briefly, the idea behind this is that the more the cardiac output or the stroke volume changes with mechanical ventilation, the more likely the patient is fluid responsive. And we have different categories of indices. The most popular one is the indices related to the respiratory variation of stroke volume, pulse pressure variation, or stroke volume variation. And just briefly, you know that pulse pressure variation is very popular. If you have a high PPV, high pulse pressure variation during mechanical ventilation, only of course, this is usually associated with fluid responsiveness. And the opposite is true. And if you have a low PPV, please do not give fluid to your patient. If you have a high PPV, think about the opportunity or not to give a fluid. And this is the first study showing that PPV, pulse pressure variation, was very predictive of fluid responsiveness compared to cardiac filling pressures. And there are many studies confirming this. But there are many limitations to use these kinds of indices, pulse pressure variation, stroke volume variation, or others, in ICU patients. And this is why we need to have other tests. The tidal volume challenge is another test. You know that during mechanical ventilation with low tidal volume, it is difficult to interpret PPV, especially when PPV is low. And this is well illustrated by this study from Laurent Muller, Jean-Yves Lefranc and colleagues, who showed clearly that you can have a low PPV in responders in patients who receive mechanical ventilation with low tidal volume. And this is a very big issue in patients with ARDS, for example. More recently, with Sheila Malhotra from India, we confirmed that PPV measured at 6 ml per kilogram tidal volume is not predictive of fluid responsiveness, not enough if you want, but we propose to increase tidal volume from 6 to 8 ml per kilogram to look at the changes in pulse pressure variation just for 1 minute. And this is a tidal volume challenge. And when we did this, we observed that the value of PPV at 8 ml per kilogram was far better to predict fluid responsiveness, but what was excellent was a change in pulse pressure variation when we changed tidal volume, and we found a cutoff value of 3.5%. In other words, if you have a pulse pressure variation value of 7%, while the patient is ventilated with a low tidal volume, you increase tidal volume, and now if the value is 11%, so 4% difference, you can predict that the patient would respond to fluid administration if you decide to give fluid. If PPV increases from 7% to 9%, you can refrain to give fluid. And this was confirmed recently by a study we performed in my unit with Dr. Takeri, Xavier Monet, of course, and others, where we showed that an increase in PPV during the tidal volume challenge is also reliable to predict fluid responsiveness. So this is a confirmation study, and there are other studies who also were published. And this is very helpful in the absence of cardiac output monitoring, because, of course, you have just to look at the change in PPV, not any measurement of cardiac output. And this is very helpful in my experience in COVID-19 ARDS patients, because these patients are ventilated with low tidal volume, and they receive a high sedation, and therefore PPV is very well, it's possible to very well interpret PPV and to perform this tidal volume change. Also, in the conditions of neurosurgery during prone position, and neurosurgery, the group of Maurizio Cicconi confirmed these results, showing that the delta PPV during the tidal volume challenge very well predicted fluid responsiveness, while PPV alone did not. And expiratory occlusion test is another possibility. This is also a test using heart-lung interaction. And you know the principle is to interrupt the ventilator for 15 seconds at the end of expiration, and this mimics a free challenge or preload challenge, because preload increases transiently. And you can measure something, stroke volume, cardiac output, or surrogates of cardiac output during the test, and you can identify fluid responders and non-responders. This is a meta-analysis with Francesco Gavelli and Dr. Ruishi and Xavier Monet and others, where we included 13 studies that all address the issue of fluid responsiveness using the anti-expiratory occlusion test, and we found good results. The summary area under the ROC curve was 0.91, and we found a cutoff value of 5%. 5% means that you need a very precise technique to measure cardiac output. You cannot rely on thermodilution, you cannot rely on echocardiography in this case. You should rely on very precise cardiac output monitors. More recently, we tried to replace cardiac output by other techniques. And for example, we looked at the changes in the plethysmographic perfusion index during the test, and this paper was published recently. Alexandra Burton was one of the authors with Xavier Monet and Nello De Vita, who is on the first row. Hello. And also bioreactants. Non-invasive cardiac output monitor also could do the job of predicting fluid responsiveness using the expiratory occlusion test. And this test worked very well in RDS patients when the compliance of the lungs is low and when the patient is ventilated with low tidal volume, better than PPV. It is very helpful also in COVID-19 ARDS patients. Peripheral Perfusion test is another possibility. You can use it in whatever condition you want, in patients who receive mechanical ventilation, as well as in patients who are non-intubated. And you know the principle of the test, just moving the bed of the patient from the semi-recumbent position to a position where the trunk and the head are horizontal and the legs elevated at 40-45 degrees. It mimics fluid challenge, but unlike fluid challenge, no drop of fluid is infused and the effects are totally reversible, meaning that there is no risk of pulmonary edema if you want. Of course, you have to assess the response to PLR to predict the response to volume infusion. This is a meta-analysis, old now, 2016, with Xavier Monet, Paul Merrick, where we included 21 clinical studies, all address the issue of prediction of responsiveness using PLR. Almost 1,000 patients were included. And you can look at the results. The summary area under the RO curve was excellent, 0.95, to predict responsiveness. It is better than PPV in patients who are ventilated or not, but with spontaneous breathing activity. It is far better than PPV if we rely on this study. And also, it is very useful in patients with ARDS, low compliance of the lungs. Again, the study we did with Xavier Monet, where we showed that it was far better to look at the change in cardiac output during PLR than to use pulse pressure variation in this situation. Again, it is very helpful in COVID-19 ARDS patients. You need to use a real-time cardiac output monitor or assessment of cardiac output because the effects are very transient. Again, this meta-analysis showing that you cannot use a change in arterial pressure. It is not bad, 0.77 for the area under the RO curve, but it's not very good, and we have a lot of false negative cases. You also can use the change in PPV, pulse pressure variation, during perceived grazing. And this worked very well. In this recent study I already talked about, we show that a decrease in PPV during PLR is reliable to predict responsiveness, far better than PPV alone. This is an option because you don't need any cardiac output monitor to do this, and it is very helpful again in patients with COVID-19. This recent paper published in a BGA with Olfa Imzaoui and others, we also showed that in patients who receive mechanical ventilation, but with some spontaneous breathing activity, you can use the change in PPV during PLR, and a decrease in PPV during PLR can predict responsiveness. This is not perfect. The area under the RO curve is 0.78, but it is better than the baseline value of PPV or anything else. You cannot use a change in CVP during PLR to predict responsiveness. This does not work. This is another study we did with Olfa Imzaoui. Be careful in patients who have intra-abdominal hypertension, because in these patients, PLR does not work very well. This is a study we did with Alexandra Burton. In patients with intra-abdominal hypertension, we have a poor ability of PLR to predict responsiveness compared to patients without intra-abdominal hypertension. So my conclusion, in patients with shock, despite initial resuscitation, it is important to assess fluid responsiveness as often as required, since fluid responsiveness is a dynamic phenomenon which can evolve over time. Today, we have many reliable dynamic tests, and even in case of fluid responsiveness, it is very important to assess the benefit-risk ratio before any fluid infusion, especially in patients with associated ARDS. The benefits can be assessed by the degree of fluid responsiveness, not the presence only, but the degree of fluid responsiveness, and the risk by indices of lung tolerance, PF ratio, lung water, POP, B lines, if you use the lung ultrasounds, etc. I would like to thank you very much for your attention.
Thank you, Jean-Louis. We have time for just one question, a quick one. So Just, Jean-Louis, did you test the relationship or not between the PPV and the capillary refill time? Did you test this?
We didn't. What is your idea behind?
My idea is just to see if there is a link or what is...
PPV is a test of peripheral responsiveness, just the response of the heart to increase its stroke volume. Capillary refill time is a test of, is a marker of perfusion, peripheral perfusion. So, of course, both are important. We have to integrate all the variables. They do not answer the same question, but it's important to integrate this, and it's important to have some markers of peripheral perfusion, as said by Jacques Retter, probably as said by Jan Bakker, by you, by everyone, of course. But it is two different tests, two different questions you want to answer.
Thank you.
Thank you very much.
So we are delighted to invite to the podium Michel Schou from Sweden, and we will cover the heart. We begin with the left heart.
Thank you very much for asking me to come today. I'll have first slide there. I've just got a couple of disclosures, but not actual conflict of interest to declare. So, ladies and gentlemen, I've just put to you that the left ventricle is important to consider during this era of COVID-19, where there is so much focus on the right ventricle, as I'm sure Antoine Villard-Baron will tell you about in the next lecture. And left ventricular dysfunction does occur very commonly in critically ill patients. Presumably, it occurs most often in patients with pre-existing cardiac disease, where acute illness causes a decompensation of ventricular function, for example, in patients with cardiogenic shock, who are not uncommonly admitted to at least my general ICU for hemodynamic stabilization prior to, let's say, an interventional measure. However, left ventricular dysfunction also occurs in patients without prior or without pre-existing cardiac disease. And good examples of these may include patients with septic shock or, for example, Takotsubo syndrome. Now, the most common method of assessing left ventricular dysfunction in the critically ill population is by bedside echocardiography. And many of you will be already familiar with these sorts of techniques, say estimating the left ventricular ejection fraction, LVEF, by simple eyeballing or using the Simpson's method. And note that the old method of the Tychols, where you measure the left ventricular dimension, is now outdated and no longer recommended. Now, although LVEF is the classically reported indicator for left ventricular systolic function, evidence now shows that the EF is not sensitive enough to detect intrinsic myocardial injury. So, a number of other conditions also have this feature, such as patients suffering from Takotsubo and anthracycline-induced cytotoxicity. However, we do know that LVEF does not have a prognostic role in patients with sepsis. And I'd like just to... Sorry about that. So I'd like to just bring to you the attention of the recent recommendations of the Price's consensus. Now, in this consensus, the recommended measurements for left ventricular dysfunction now include not just the LVEF, but the MAPC, the mitral annular plane systolic excursion, which is just the left ventricular analog of the TAPC, the tissue Doppler S prime wave, as well as strain measurements, including the global longitudinal strain. So what the Price's consensus also recommends is to report the presence degree as well as the location of regional wall motion abnormalities. This is an old type of measurement and perhaps not so fancy anymore, however still important, and it's still reported according to the 16-segment model of the heart. And this includes a description of not just the severity of the abnormality, mild, moderate, or severe dyskinesia, or even hypokinesia, or even dyskinesia, but you can also quantify it as a wall motion score index. I know this is not commonly done in critical care, but it is a good measurement that will quantify the degree and severity of regional wall motion abnormalities. And for patients with cardiogenic shock, the LVEF is still an important metric, playing not just a diagnostic role, but it's also important for monitoring the effects of treatment. It also plays a prognostic role in contrast to patients with septic shock. And to illustrate this, what I wanted to show you was this was a 45-year-old man who came to our unit. He initially presented with, he was a heavy smoker and presented to the CCU. He had a left main stem occlusion. It was stented. He deteriorated and was admitted to our ICU with cardiogenic shock. And an echo was requested prior to insertion of an intra-aortic balloon pump. And what I just wanted to show you was a severe dyskinesia of the anterior lateral walls as well as the apex. And that tells me that the question we need to be asking is this a stent reocclusion? So that's all I wanted to show you. Now, the event of advanced scanners capable of speckle tracing has identified strain, and in particular, the global longitudinal strain, GLS. You might have heard of this as the new gold standard for a left ventricular systolic function assessment. Now, some of you may be already familiar with this kind of measurement. No, I just pulled this out from this journal. This is a patient with Takotsubo syndrome triggered by an emotional cause. Now, with these kind of 17-segment bullseye plots, you will see the strain measurements. The more negative the number, the better the contractility. So it's the opposite to what you might think. So the red are normal contractility, and the blue is poor contractility. And this is day 1, and you will see this very poor contractility at the apical and surrounding segments. And by day 4, it had recovered. By day 21, complete recovery. So the recommendations from the Price's consensus in the critically ill population are in line with current guidelines as well from the European Society of Cardiology, and it includes the measurement of strain to detect subclinical disease. And in this recent review, the prognostic and diagnostic implications of left ventricular systolic function are addressed. In brief, what the document says is that deteriorating left ventricular systolic function predicts poor outcome and helps guide treatment decisions in a variety of pathological conditions, including coronary artery disease, ischemic heart failure, but also amyloidosis, pregnancy-induced cardiomyopathy, and valvular heart disease. So left ventricular dysfunction is important. However, this paper does not address the critically ill population. Now, if you look at the critically ill literature, it's replete with a lot of studies, mainly measuring left ventricular systolic function as the LVEF. Most studies address systolic function in patients with septic shock, and you will find that most of the literature will show you that there is no relationship between the LVEF and outcomes in terms of mortality in patients with septic shock. So this was a meta-analysis done by the Sydney group, but even if we are looking at other indices of LV systolic functions, such as the TDI S-wave, you will find no relationship with mortality. So LVEF and TDI, the tissue Doppler S-wave, does not appear to be prognostic of outcomes in this group of critically ill patients. Well, what about the newer indices, such as strain? Well, this meta-analysis would suggest that strain does have some prognostic implication. It is thought to be a more sensitive indicator of subclinical left ventricular disease, identifying disease even in patients with a normal LVEF. However, the data regarding GLS, or global longitudinal strain, is still unclear, and we still do not know if it is prognostic of poorer patient outcomes. Now, I just want to mention a couple of new variables, and that is the MAPC. The MAPC, the mitral annular plane systolic excursion, as well as this index, the LWLWS. So left ventricular longitudinal wall shortening, which is just a MAPC normalized to the left ventricular length. Now, like GLS, these indices are thought to be more sensitive for the detection of subclinical left ventricular myocardial dysfunction. And the major advantage of these techniques is, unlike strain, which is quite difficult to do, and it's not a bedside technique, these techniques are highly feasible. You can get it in over 90% of your critically ill patients at the bedside. And we and other investigators have demonstrated that, at least for MAPC, there is an independent association between that and outcome. Now, what about diastolic dysfunction? Studies suggest that diastolic dysfunction measured using tissue Doppler indices may be independently associated with mortality. The caveat, however, is that few of these studies, actually there was only one study that adjusted for pre-existing cardiac disease, so we still do not know whether diastolic dysfunction of the left heart is associated with poor outcomes as an independent factor or simply a reflection of underlying heart disease. So, let me put to you that the prognosis of critically ill patients with left ventricular dysfunction actually varies according to underlying disease. Certainly for patients with Takotsubo syndrome, heart failure, anthracycline toxicity, amyloidosis, for example, left ventricular dysfunction, regardless of how it is measured, does have prognostic significance. However, it does not seem to have prognostic significance, at least when measured using the LVEF and the tissue Doppler S prime for patients in septic shock. Diastolic dysfunction seems to be predictive of poor outcome, with the caveat that we still do not know if it is an independent predictor of risk. So, ladies and gentlemen, left ventricular dysfunction is a significant pathological finding. It is associated with low cardiac output states, which in turn has real implications for organ failure. So let me just leave you with this last video. A 17-year-old patient who came into my unit with septic cardiomyopathy. This echocardiogram was taken on admission. He deteriorated quickly and within 1 hour of admission was in fulminant septic shock on multiple vasopressors and inotropes. Multiple organ failure ensued with respiratory, cardiac, renal, and coagulation impairment. He required veno-venous ECMO and made an excellent recovery. So although left ventricular systolic function measured using EF does not seem to be prognostic for mortality in patients with septic shock, I put to you that it is still a relevant finding that should not be ignored. Thank you for listening.
Thank you, Michelle, for this overview. We are running a little bit over time, but one quick question. Among the different variables, which one you use to decide to treat your patients? You don't treat MAPC, or you treat MAPC, so which one you use to treat your patients?
You know, the correct answer to that is I don't use any of those variables to treat my patient. I look at the whole patient. I use, you know, the MAPC, I use the EF, I use the cardiac output. We even look at tissue perfusion. We've started to look at that now. So it's a bit of the puzzle. As with many of these investigative techniques, we don't rely on any single variable to treat the patient.
Okay, but to be more clear, when you have a low cardiac output, or when you have when you're high cardiac output and you have the same variables, you decide based on cardiac output, you decide based on tissue perfusion, you have your trigger, and then you have indeed your different assessment of ventricular function. So which one you use preferably at bedside to decide to initiate inotropic agents?
Yeah, my favorite at the bedside is MAPC. Okay. Yes.
Thank you.
Thank you. So now the right ventricle. Do we disregard right ventricle dysfunction? Antoine Vierbaron.
Okay, thank you. Good afternoon, everyone. Of course, we do not disregard the right ventricle, Jacques. What a curious idea. I do not have any conflict of interest for this lecture. So first of all, I want to start to be very honest with you and to tell you that if we speak about right ventricular injury in general in the critical care setting, Finally, the debate is still open. There is not very clear definition, and it's a big deal because we need a good definition to have a better characterization, epidemiological data, and so on, to try understanding better exactly what happens for the right ventricle in the critical care settings, and especially in case of shock. And just briefly, I may summarize that you have two different approaches that could be complementary associated. It's not only one or the other, could be associated, but once again, we miss data to be more clear. The first approach is, let's say, I will say a more cardiological approach, which is to use a parameter of systolic function that you may get from echocardiography, TAPC, fractional area change, S prime, which is also applied on the right heart, strain also applied on the right heart, or even ejection fraction using the MRI. So you may have right ventricular systolic dysfunction in case of one or all of these parameters are decreased. Or you have another approach, maybe more understandable by the intensivist, I don't know, which is to define right ventricular failure as a congestive state where the right ventricle is dilated with, for instance, an elevated CVP, exactly what you can observe here in patient ventilated with ARDS and with shock. You see that the right ventricle is much bigger than the left ventricle. So at that stage, we don't know exactly what is the best approach or how to combine both. But in all cases, do not disregard right ventricular injury, I will say, not dysfunction, not failure. First, this is very obvious because the LV stroke volume determines the LV preload, and so at the end, the LV stroke volume and the cardiac output. And this is something in a patient under positive pressure ventilation that you may visualize very well. Here, this is RV stroke volume, cardiac beat per cardiac beat along the respiratory cycle. You see just at the beginning of the tada inflation that the RV stroke volume start to decrease for a major decreasing at the plateau. If you look at now in the same patient the pulmonary vein, and so we were able to record the pulmonary venous return, you see as a consequence a decrease in the pulmonary venous return, let's say at the end of the inflation, beginning of the expiration. And so as a consequence, if you look at, at the left side, here, this is the LV stroke volume, cardiac beat per cardiac beat. You see, as a consequence, because the LV preload was decreased, you observed a decrease in the LV stroke volume during expiration. So this is very simple and obvious, but very key to keep in mind when you want to better manage the patient and resuscitate the patient. The second reason is that because it is a very usual cause of shock in the ICU. You know probably this figure. You have summarized most of the causes of RV failure-related shock that you may observe in the critically ill patients. You may have decreased contractility because of sepsis or infection, but most of the causes are usually related to pressure overload because many or all of our patients are under positive pressure ventilation. And I just want to give you some epidemiological data very briefly about the causes. If you take patients hospitalized in the ICU for a pulmonary embolism, so it's a very selected subgroup of patients, the incidence of right ventricular failure is around 60%. If you take now a patient hospitalized for a cardiogenic shock-related myocardial infection, you will have RV injury or RV failure in around 5%. And finally, for patients admitted for septic shock, if you systematically record the RV function, probably you have an incidence around 40%, and I did not give you here the incidence of patients with ARDS, which is around 20 to 30% of RV failure, despite the use of protective ventilation. The third reason is that clearly we know that it impacts the outcome. You have this study performed in less than 400 patients admitted in the ICU with severe sepsis or septic shock. This is the approach that I show you because they try to characterize the RV function using, let's say, cardiological parameters, the AV fractional error change, or the TAPSE. And so they were able, using this approach, just to tell us that at least half of patients had RV dysfunction, and this RV dysfunction in this septic shock patient was associated with a significant lower PO-NF ratio, so less oxygenation, which has a strong physiological rationale. And what was, let's say, so interesting in this study is that right ventricular dysfunction, as defined here, were independently associated with the outcome, among other parameters and variables. We know also in acute respiratory distress syndrome, moderate or severe, submitted to protective lung ventilation, that severe cor pulmonale, which could be something that than RV failure, is also associated independently with a worse outcome in our patients. The fourth reason is that, as a consequence, of course, it will modify your management, and especially the way you manage the fluids and the way you manage the catecholamine requirement. Sorry, we have some trouble with this device. It's very bad, the green and the blue, but sorry. So just to tell you that you have different parts of the, for the RV support. You have the hemodynamic strategy, of course. I try to summarize with norepinephrine infusion and fluid restriction. You have some specific strategy, yes, more related to the cause of the RV failure. Could be fibrinolysis in case of severe pulmonary embolism, could be prone position in case of severe RDS, could be diuretics, why not, in patient with a decompensated heart failure, with an injury of both ventricles, and of course a respiratory strategy, because if you apply a positive pressure into the lung, in this patient you absolutely need to limit a certain parameters we may act on the pulmonary circulation, and as a consequence, which may worsen the RV function. I just want to illustrate in a few slides about the fluid management, which is probably the key problem or the key issue. The first is that when the RV is dilated, you know that probably it limits the usefulness of the volume expansion, and I mean it will limit the response to fluids. You have here the size of the RV in responders to fluid before fluid expansion, and here the size of the RV in non-responders. You see that the non-responders are the more dilated RV, so definitively it decreased the efficacy of the fluid expansion. The second point is that the second study we have is the recent study we published with my group. It's a little bit complicated figure, just I try to explain you very briefly. You have here on the x-axis the size of the RV, and on the y-axis the pulse pressure variation, and I will discuss a little bit later about that. More green is the color, less likely is the patient to respond to a passive leg rising, so a reversible fluid challenge, and more orange is the color, more likely is the patient to respond to the passive leg rising. Just look at here, for instance, this is very well expected. When the RV is non-dilated and you have significant pulse pressure variation, it is very likely that the patient will respond to fluids. But look at this more interesting upper and right corner. You have significant RV dilatation, and despite significant pulse pressure variation, the patient were very unlikely to respond to fluid. So this is definitively a limiting factor for the response. And even it could be deleterious. And as I probably discussed yesterday, I showed this slide. We do not have so many human studies about the deleterious effect of giving more fluids when the right ventricle is failing, but we have many experimental studies. And here I show you this one. This is an experimental study which inducing obstruction of the pulmonary circulation, so mimicking pulmonary embolism in animals. You have the baseline with the stroke volume, the cardiac output, and the right ventricular and diastolic pressure. After inducing the obstruction, decrease in cardiac output, stroke volume, increase in the pressure into the right heart. After giving more volumes to the animal, more decrease in the cardiac output stroke volume and more increase in the pressure into the right heart. So not only useless, but even deleterious. And finally, this is the norepinephrine infusion, which was capable here to restore an adequate hemodynamics. I show you this just a case in a patient which was admitted in the emergency ward, finally for urinary sepsis, but it was not known at that time. And because it was in shock, she received fluids and fluids and fluids without any efficacy on the blood pressure. And finally, she was admitted in the ICU with an abdominal pain, which was finally no more than a liver congestion, a cardiac liver. And when we did the echo, you see this is a transthoracic echo that the RV was very, very dilated, at least bigger than the LV. Look at how the IVC was also dilated, reflecting the congestion of the liver and also of the kidney in this young lady. And because both ventricles were injured in this case, even if it's not so obvious here for the LV, but trust me, there was a left ventricular systolic dysfunction very severe, we decided to stop fluids, of course, and just to infuse small dose of inotropic drug. So it doesn't work. We have trouble, technical issues. It works, okay? And look at now the RV, much lower, much less dilated. The patient was more tachycardic, but the LV was much better. And look at the IVC. The IVC was in a normal diameter. So, and the patient at the end, of course, because we do not want to treat an echo, we treat a patient, the patient significantly improved. C'est compliqué, hein, votre... Okay, sorry. So just I want to illustrate also the fact that the echo should be combined with other parameters and other approach. Don't do the echo alone. First, that's obvious, but when you have to to manage a patient in shock, you absolutely need to have an invasive blood pressure, just to have a continuous monitoring of the blood pressure. But you know also, as shown just previously, that you're using that, this gives you some information. So I agree that in most cases, probably that the patient will be a fluid responsiveness. But we know that because of this effect of mechanical ventilation of the RV stroke volume, we have some patient in whom finally this pulse pressure variation is more related to RV afterload. And so you have to adapt the treatment, not give him more fluids, but probably to think about more better adapting the respiratory settings. So you need the pulse pressure variation. There is no doubt about that. But probably at the opposite, maybe to Jean-Louis, I will prefer to use it as a warning signal that there is a bad interaction between the ventilator and the RV function, and so some issue with the right ventricle, and so I need to do an echo just to look at what happens. And just look at this patient. It was exactly what we did in this patient with pulse pressure variation. And when we put the TE probe, this is what we observed. A very big RV, a very big right atrium, so a very severe RV failure. So you really may adapt the treatment differently. Another parameter, there is no discussion absolutely that you have to associate with the echo is the CVP. Because you know that RV failure-related shock, this is by definition sign of shock, but this is also sign of congestion and especially an elevated CVP. Look at this patient here. This is not through a central venous line. This is through a pulmonary artery catheter in the past. But look at how the right atrial pressure was high, and even it was higher than the pulmonary capillary wedge pressure. So this patient was in a very, very bad shape with a very bad right ventricular function. Probably it's a too extreme situation to improve the situation. This is probably too late. So try to avoid that. And in this study that I show you in our patient with septic shock, all invasively ventilated, we try to look at the distribution of patients according to patient without any RV dilatation, with some RV dilatation but no significant elevated CVP, we decided to take a cutoff value of 8. I have no time to tell you why. And a third group with the association of dilatation with a CVP at least higher than 8 millimeters of mercury. And it was 42% of cases that we observed this kind of patient that could suggest significant RV injury or even RV failure. So I want to conclude. There is no consensus to define RV injury. Is it failure and how to define failure? Is it systolic dysfunction and how to define systolic dysfunction? We have a better idea. RV failure dysfunction is an usual cause of shock in the ICU because RV stroke volume generates pulmonary venous return and then LV preload. RV failure and dysfunction is associated with a poor prognosis. I don't say, because it's difficult to say that it is the cause of the mortality, but we have a lot of data suggesting that. Echo definitively will help you in detecting and managing right ventricular injury, but always in association with other parameters, the CVP, the blood pressure, and the delta PP. Fluid expansion is definitively useless and even deleterious in case of RV failure or significant dysfunction. And I thank you for your attention.
Thank you, Antoine.
Thank you. Before taking the questions, may I recall, I see some people without mask. I mean, put your mask on the nose because it's in your nose. It's very important. We have face-to-face meeting. We cannot have face-to-face meeting in future if people do not comply. So thank you very much in advance.
Thank you.
For the speakers, of course.
Yeah, yes, but I put it already.
Yes. Okay. Do you have question with the mask? So, just Antoine, when you have a right ventricular failure and you try to limit fluid, so there is two index, it's the PPV and the CVP. In practice, do you have numbers that we try to find, for example, PPV greater than, I don't know, before you give fluid greater than 20%, or is there something in the literature about this?
So no direct data. This is just the application of what was described for fluid responsiveness concept. And they considered with many studies that this is significant when this is above 13%. So I will consider this magic number. But once again, this is probably more a continuous process. And I mean, let's say if you have 8% on the morning and 12 or 11% on the afternoon, maybe you have to consider doing an echo just to check for the RV function. And about the CVP, that's difficult to say. I give you the limit of 8 millimeters of mercury, because if you look at the cardiological literature, and especially an old paper from Mullens about decompensated advanced heart failure, he very well reported that when the CVP remained higher than 8 millimeters of mercury after the initial resuscitation, which was more to support the heart and to do depletion and so on, this patient had more acute kidney injury due to congestion. So this is why we try to take the 8. But once again, this is more a cutoff magic numbers, so I do not have so many papers to support that cutoff.
Thanks a lot.
Antoine, when you discuss the right ventricle and the congestion, do you think we should pay attention to the flow in the vena cava or flow in hepatic veins or whatever? I mean, some people, especially Dono and others, have put forward the fact that looking at respiratory variations in these flows can be interesting?
I think you are right, because you can do the analogy with the left side, where usually we look at surrogate of LV filling pressure. We have exactly the same for the RV filling pressure. You may have absolutely typical pattern, especially in the subhepatic vein, reflecting congestion and high pressure into the right heart. I did not speak about that for 2 reasons, or for 3 reasons. First, it's a little bit too echo for me. I mean, it's not a session about echo. This is about treating patient. Second, I think it's not so easy to record at the bedside because of the movement of the diaphragm and so of the liver. And I forget the third reason. So
There was a question there. I don't know if there is a microphone. Yes, the microphone is coming.
No,
Not yet.
So the question, I
yes.
think, is
Thank
what
you.
is the adequate catecholamine to support the RV? I think this is your question. Yes, catecholamine in general. I mean, including milrinone, levosimendan, and it depends. Once again, I say something, we do not have data to support that, or at least no data. Well, I tell you what I do in my unit. You have the situation where you have an isolated RV failure with a very good LV systolic function. In this situation, we prefer norepinephrine infusion because we know that it restores the perfusion of the RV and it may help the RV to better act. You could consider maybe levosimendan in RDS patient because there is 1 or 2 studies, but I think we miss data, and it could improve the coupling between the RV and the pulmonary circulation because it may induce a vasodilation of the pulmonary circulation. And the second situation, finally, is then you have both, as I show you, injury of the right heart and the left heart. In this situation, we prefer infusing the butamine because here, if you infuse norepinephrine, probably that you will worsen the LV systolic function by increasing the afterload because the LV is still in a very bad shape. So we prefer small dose of the butamine, but not too high dose because of the tachycardic effect.
So thank you very much.
Okay, thank you.
It's time to move on. And so I think we go for Jan Bakker and one of his 2 talks. The first one, perhaps in opposition to the last one, but we'll see. Can blood lactate levels used to guide therapy? Jan from today, New York?
Today I'm from Brussels.
Brussels,
Yeah.
okay.
So thank you for the introduction, Daniel. Can lactate be used? The answer is simple, yes. The more difficult is how, because that's a huge difference. There is no continued interest anymore for lactate by the industry as all the continuous lactate devices have failed. This is what I said about 20 years ago at the same meeting. Increased lactate levels universally mean trouble. Response to therapy, especially a failure of a response, so a failure to decrease lactate is related to morbidity and mortality. Lactate levels could serve as a marker of effective patient care, and it's a consistent marker of severity of disease. And this is the thing I will focus on, is targeting normal lactate levels in therapeutic schedules, so in the treatment of circulatory shock, still beneficial? I thought it was beneficial 20 years ago, but is it still beneficial? Well, Max Hariwal basically introduced lactate into the clinical field. He did that in most of his research in cardiogenic shock, and he said lactic acidosis is a sine qua non of oxygen deficit and presently represent the best single objective measure of a perfusion failure. And that's how we have been using it since Max Hariwal said this in the 60s, I think it was. So that's a long time ago, and we still use it as a marker of perfusion, and I see a lot of reflex medicine. You come in with a lactate and you get a liter of saline. Is lactate helpful? Yeah, it's very predictive of outcome, and that's not changed for a very long time. This is the control group of the lactate study that I will present a little bit later that we did in the Netherlands, a multi-center study, and in the control group we didn't chase lactate, but of course we measured it, and as you can see, this is only a few years ago, there was no survival when there was a lactate above 10. And remember, the entry criteria was you had to think that there was a circulation problem in the patient with a lactate more than 3. I will show you that this has to change. We just finished a study in Bellevue Hospital, which is not only a specific hospital, but has even more specific patients. Now, lactate is more important than hypotension. That's what I said earlier in the lecture about accepting hypotension as a strategy. If you have hyperlactatemia in septic shock and you have hypotension, your mortality is way higher than when you have no lactate. So lactate is an important signal that something more is wrong than just a blood pressure. And changes in lactate, as Jean-Louis showed when he reviewed all the studies that measured lactate at least twice. And what he showed in this study is that almost in every concept, in every context of critically ill patients, when lactate goes down, that's good. That's a good signal. It's associated with a much better prognosis than when your lactate increases or doesn't change, or start to increase halfway when it is decreasing and it starts increasing again. That's a bad sign. Doesn't tell you what to do, doesn't tell you what's going on, but it should make you nervous. So to date, this is the only study that compared measuring lactate, trying to optimize tissue perfusion, tissue oxygen delivery based on repetitive lactate levels and see if you can improve outcome. And the important aspect of studies like this is, of course, the protocol. It's not the thought whether lactate is the key element of tissue hypoperfusion or tissue hypoxia. It's also the protocol that, at the end of the day, may make a difference. And there are a few key elements in the protocol in how we used lactate in that study. Well, first it was lactate above 3. So it's a little bit, let's say, more than the upper limit of normal, which is around 2. And then we divided the patients in likely low flow state, SCVO2, and likely a hypodynamic state. And interestingly, the only study to date, this is the group where we infused vasodilators to improve and open up the microcirculation and improve perfusion. And this protocol was based on DO2, the oxygen content, the oxygen delivery, read cardiac output, and in this study we also targeted oxygen demand. So if a patient was in a severe pain, if the patient was fighting to breathe, we put the patient on a ventilator or gave analgesics. The other important thing is this was 8 hours. After that, the study stopped. And so you had to do your trick in the first 8 hours of admission. And we showed that ultimately the p-value was 0.06, so it just missed statistical significance. But at the end of the day, we showed that there was a signal that probably using lactate for a limited time, 8 hours, and using this algorithm could have an impact on outcome. Oh, well, the question is it 8 hours? Should you do 12 hours? Do you do 24 hours? Surviving Sepsis campaign thinks about lactate normalization in 24 hours. So we had the idea that in septic shock, probably in the early phase, there is absolutely a perfusion problem. But later on, when you have fixed the perfusion, you can still have lactate. And the origin of that lactate is probably different than the origin of the lactate in the beginning. And to test that, we studied surviving patients of septic shock. So we took 31 septic shock survivors and we measured the normalization of lactate over time in the survivors, and we had 6 hours was the first measurement, 2 hours, 6 hours, 12, 18, and 24. And this is normalization of lactate, and this is the normalization of perfusion parameters. This is the delta PCO2. I will talk about that in my last presentation. And this is capillary refill time. And what you can see is that there is a steep curve for both the normalization of lactate and the normalization of perfusion abnormalities like delta PCO2 and CRT up until 6 hours. And we found in another study that we did somewhat later is that if you have lactate and these markers of hypoperfusion, that the outcome of these patients is worse. And so the question is this really hypoperfusion? Because they don't have the markers anymore, because it's clearly almost normalized in the majority, and given the combination with this study, it's really the question whether after 6 hours in this study, there is really hypoperfusion causing an increase in lactate or a non-decrease in lactate. And 50% of these surviving patients, it's 31, so don't make a lot out of it, it's only 15 patients, but still 50% of the surviving patients still had abnormal lactate 24 hours after admission, after having corrected their perfusion abnormalities. And that's why we said, okay, if this perfusion indicator in the early phase of septic shock is reflecting the increased lactate, then maybe a perfusion indicator is more useful than lactate in and of itself. No studies, so we had to test it, and that's why we did the Andromeda shock study. I won't go in all the details, but basically what it is you either corrected capillary refill time and then stopped resuscitation, or you corrected lactate, or you had a decrease of 20% every 2 hours, like in the shock study, in the lactate study that we did previously. And also in this part, it's important to recognize that there was a protocol. So if you want to, let's say, repeat the study, you have to use the protocol. You cannot just do, well, I do it very differently, because that's not what we showed. What we showed is that you use fluid responsiveness to begin with. Then if you think blood pressure is inadequate, you do a vasopressor test. You transiently increase vasopressors to see if it affects the decrease in lactate that you're aiming for in the control group, or the decrease or the normalization of capillary refill time in the protocol group. And if you think blood pressure is not a problem, you do an Inode Dilator test, and in this study we used dobutamine. In this context, also a P of 0.06, it seemed that this strategy of, let's say, normalizing capillary refill time or using a normal capillary refill time as an end of your resuscitation, that improved outcome. The Bayesian analysis that we published in the Blue Journal clearly showed that in clinical terminology, this was superior to lactate. But in the sub-studies, we showed more. Remember, the Surviving Sepsis campaign uses a lactate of 4 to indicate severe perfusion abnormalities. Well, we showed that if you have no perfusion abnormality, in the sense of capillary refill time, then either having a lactate of 2 to 4 or a lactate above 4, there is no difference in outcome. It's only if you combine the increased lactate of more than 4 with an abnormal perfusion indicator, like we showed in the other studies. So the combination of a perfusion abnormality, whether that's capillary refill time or SCVO2, or maybe delta PCO2, that combination is something you should really target. But if your capillary refill time is normal, it doesn't seem to benefit to target lactate. It's even worse. If you target lactate with a normal, in patients with a normal capillary refill time, so this is the lactate group in the Andromeda study, the target is decreased lactate, not normalized capillary refill time. So if your lactate doesn't decrease, but you have normal capillary refill time, you continue resuscitation in this group. It's different in the peripheral perfusion group, where you would stop resuscitation as soon as your capillary refill time was normal. After the first 2 hours, chasing lactate in a patient with normal capillary refill time doubles mortality. That doesn't mean that you kill them, but it means that targeting lactate in a patient without perfusion abnormalities, even already after 2 hours, doesn't seem to really benefit the patient. Now, the problem with lactate is that in the early hours, it's probably related to perfusion abnormalities, but there are a lot more reasons to have an increased lactate where there is no perfusion abnormality. And of course, then doing reflex medicine, give a liter of fluid, is unlikely to help the patient. And that's what we argued in this paper, the 10 pitfalls of lactate clearance in sepsis. Now, what we did is, okay, if this is true, if there are so many other variables or processes that influence your lactate, and if after normalizing your perfusion abnormalities, lactate may still be increased, then what's the context of lactate? Is lactate different, or let's say the prognostic value of lactate different in different circumstances? And that's why we went to the population in Bellevue. I worked for some time in Bellevue as well. And Bellevue, when compared to NYU, where I have my clinical practice now, is Bellevue has about 5% of the patients having insurance, whereas NYU has about 95% of the patients having insurance. And in Bellevue, you see people that live on the street. You see addicts to alcohol, to drugs, a patient with diabetes that I didn't take my insulin this week because I didn't have money, and so maybe next week I will take my insulin if I have money again. So this, let's say, poor population in bad conditions, they have maybe access to treatment, but not on a regular basis. And so we looked at comorbidities in these almost 1,400 patients, more than 1,400 patients: polysubstance abuse, renal disease, liver disease, malignancy, diabetes, HIV, seizure disorders, and multiple comorbidities. That was, let's say, the context of the patients. And this is what we found and what we saw in clinical practice, and that's why we did the study. The mortality of a lactate more than 10 when you came into the emergency room of Bellevue Hospital was 18%. Remember the control group in the lactate study, the mortality above 10 was 100%. That's context. Now you could say, okay, that's emergency room. What about ICU patients? Well, the ICU patients still had a higher mortality if lactate was more than 4, but still it's only 23%. And if you then make the same graph that I made in the beginning, you see the huge difference when you change the context of your lactate measurement. So this is the control group in the lactate study. As you can see, above 10, no survival. And this is the ED patients of Bellevue Hospital. And these are the ICU patients of Bellevue Hospital. Of these patients with 25 or more than 20 of lactate, some went home. A large group of these patients were discharged home. You fed them. That's usually the first thing the patients ask if you come to see them. Can I have something to eat, to drink? I mean, come on, give me some food. And so a lot of these patients were discharged home. And so you can clearly see that context of lactate is very important. So, in conclusion, lactate is a strong predictor of outcome, just like changes in lactate levels. Using lactate to guide therapy is complicated. You can use it, but it's complicated, and you have to take into account that there are other factors, especially in sepsis. The early phase is associated with parameters of perfusion, the changes in lactate. Using CRT might be, let's say, superior than lactate, and targeting decreases in lactate is difficult and dangerous, maybe, especially in patients with normal peripheral perfusion or no indicators of hypoperfusion. The value of targeting lactate beyond 6 to 8 hours is, I think, not recommended, given the data we have. And most importantly, increased lactate levels require context. And targeting lactate needs to be guided by markers of tissue hypoperfusion. Thank you very much.
Thank you very much, Jan. Any question? So when you say context dependent, and again, beyond the fact that you mentioned CRT should be used in addition to lactate, do you have other variables you use at bedside to say that you should do something on lactate?
That's a very important question, and that's of course the limitation in emergency rooms. I mean, you don't put in a CVP catheter, central venous catheter, to get an SCVO2, which is very helpful. But we also know that if you do your, let's say, normal stuff in the emergency room, resuscitate the patient with fluids and maybe some norepinephrine, you bring them to the ICU, only 10% of your patients have a low SCVO2. So if you do it in every patient in the emergency room, that's not okay. That's over-treatment in the majority. And so, yeah, we don't have a lot. So I use capillary refill time because it's simple. And as soon as they're in the ICU, and that's what I will show in my last presentation, I use SCVO2 and delta PCO2.
Thanks a lot. Thank you. So it's my pleasure to introduce Dr. Jaume Mesquida Faber. I'm sorry for the pronunciation. And my strategy to optimize oxygen transport.
Okay, so thank you so much. Dr. Bakker just made an excellent introduction for my talk. I just have to say that the title was overwhelming for me. It's like my strategy sounds a little bit too much. So I just tried to change a little bit and say, just share some thoughts about how to deal with some weak recommendations when we have to optimize oxygen transport. So the way I think we all work at the bedside, I think it's in a two-question closed loop. The first one is whether the patient has tissue hypoxia, and that has a lot to do with the previous talk and probably with the next talk about the endpoint of resuscitation. So if the answer to that question is yes, so the second question will be, how can I increase oxygen delivery to the tissues? If the answer is no, so I assume the oxygen transport is okay, so I only have to reassess that again and again. If the answer was yes, and I want to increase oxygen transport, so I just perform an hemodynamic intervention, and afterwards I reassess and go back to the first stage. So probably, if we talk about oxygen delivery, I think one very, very important question is the first one. So I will talk mainly about the second one, but I want everybody to bear in mind the importance of the first one. So I'll just go through this slide very fast because I think it was the previous talk, and as I said in two talks, Dr. Bakker will go through that again. But our whole idea when we want to increase oxygen delivery to the tissues is that we assume that we're just treating those patients who are in this area of tissue hypoxia due to low oxygen transport. So that's why we want to increase oxygen transport. That would be the lactate guided, for example, but probably if you use lactate, we will also have patients that already have a really high oxygen transport, and the oxygen transport is not the problem anymore. We can use a capillary refill time strategy, but probably, and I hope that's the last talk about the endpoints, probably we need to perform a multi-parameter approach to detect tissue hypoxia. So I will not go much more into that. And just let's assume we have tissue hypoxia, whatever that means with the markers we use. So how can I increase oxygen delivery? And I think it's just going to remember the determinants of oxygen delivery to the tissues, and that will be cardiac output and arterial oxygen content. And if we go to the determinants of cardiac output, that will be stroke volume and heart rate. If we go to the determinants of arterial oxygen content, that would be hemoglobin, how much that hemoglobin is saturated, and in an insignificant way, the arterial PO2. So I just put in red what we really might treat to increase oxygen delivery. So you recognize that probably most of the actions we do is just trying to manipulate stroke volume. And how can we do that? Today, the approach we are using to manipulate the stroke volume, and I think that was 2 talks previous to this one, is a Frank-Starling approach. That meaning that we have a preload dependent area, a fluid responsive area of the cardiovascular function, and we will give fluids if the patient is there, and we have a preload independent zone where the patient would not respond to fluids, so with stroke volume. If we want to increase stroke volume, we can only change contractility of that heart. So we will use inotropes. As I said, already shown by Professor Teboul, I think it was two talks ago. What we have a lot of indices, dynamic indices for predicting the response to fluids. And if that's not possible, we can just have a stroke volume monitoring tool and perform a fluid challenge. But at the end, the message would be that we have really reliable tools for guiding fluid administration in stroke volume optimization. So that's where our problems come at the bedside. Do we have evidence that we're just acting how we should act? So if we go to the surviving sepsis guidelines, the recommendation of using dynamic parameters is a weak recommendation. So that's surprising for me. But I can just call another experts, and they will say, yeah, using dynamic parameters is a level 1. That will be a strong recommendation. So that's a little bit confusing. If I want to manipulate oxygen transport, what should I do? A weak recommendation or a strong recommendation? I would aim for the strong recommendation. So we have a strong recommendation based on physiology. We know that dynamic parameters are reliably talk about if the patient will respond to fluids, if I want to optimize cardiac output. The problem is we cannot take decisions only thinking about the final outcome of the patient. So that was one of the questions we have to deal with. So let's assume we just optimized the fluid status of the patient, but still we have tissue hypoperfusion, and we have to use an inotrope. We have different inotropes, and we will go. I just will talk about one of them. There's not a lot of studies about all of them. So, but the first choice inotrope in most of the guidelines is dobutamine. Probably you can use another one. For example, if you want also to increase heart rate, you can use dopamine, or if you have right ventricular dysfunction, maybe you can use milrinone. But I will talk mainly about dobutamine as a first choice. So again, if we go to the recommendation, we will find that it's a weak recommendation to use an inotrope if we have persistent hypoperfusion and we have already optimized the bulimia. In this occasion, I don't have any extra help from the other group of experts, so it's also a weak recommendation using dobutamine. So if I have to use dobutamine, I just want to look at what do people do. So if you go through the different early goal-directed therapies, the use of inotropes, mainly dobutamine, is around 10, 14%. And that has not been associated to improvements in outcomes. So if you take a closer look, that would be using, that's the reverse protocol, and the other early goal-directed driven protocols are pretty similar to this one. So the recommendation is to use inotropes only when persistent tissue hypoperfusion after optimization of volume status. So if we look at the trigger for using dobutamine, we'll find that in most of the studies, dobutamine was, SCVO2 was already normal at inclusion. And if you want to take a closer look, it's really difficult because the studies did not show a lot of data about SCVO2, which was the later endpoint. But the ARISE trial in the supplementary material, it has some of that data. So, and that data shows that most of, above 70% of the patients at inclusion already had normalized SCVO2. So taking that into account, if we do some maths, that would be that less than 25% of patients had low SCVO2, and if the overall dobutamine use was 15%, that would make that more than half of the patients in the protocol with low SCVO2 received dobutamine. I think that's a lot. That's not my usual practice. So maybe we can just explain that if we go through the initial protocol. You should give inotropes only when SCVO2 is low and after optimization of volume status. And in these protocols, the optimization of volume status was based on CVP, which that's not our current practice anymore. We don't use CVP for optimizing volume status. So that might account for that bad results. Nevertheless, in the last years, we have two network meta-analysis. I cannot explain how that's analyzed, but in complex analysis, even though the protocols they analyze are not probably my current practice, both protocols, both meta-analysis trials found that there might be a positive impact on outcome derived from dobutamine use. Dobutamine plus norepinephrine, and is the other one dobutamine plus norepinephrine, and maybe levosimendan. So my final thought is probably has really my daily practice, what we really do at the bedside, been properly assessed in this randomized controlled trial with early goal-directed therapy? Probably not. I don't think that's been probably assessed. Still, I think there might be a benefit of using dobutamine in this population. So probably I have strong evidence of using dynamic indices of preload, and afterwards using dobutamine would be correct. But how about hemoglobin levels? I didn't talk so much about that. We probably, most of us only keep improving stroke volume. What about hemoglobin levels? Now we do have strong recommendations about that. And the strong recommendations are based mainly on two trials, the TREES trial, comparing two groups with hemoglobin threshold of 7 for, as a trigger for red blood cell transfusion, and an hemoglobin level of 9, and a sub-study analysis of the process trial using 2 different thresholds. There was 7.5 of hemoglobin versus 10. So I'll show you just the results of the TRIES trial. No difference in hemoglobin derived from the restrictive for the low threshold hemoglobin. And importantly, with no adverse events like strokes or myocardial ischemia. In addition to this trial, we have also a randomized, a systematic review of randomized trials with restrictive against liberal red blood cell transfusion with no impact on mortality and no adverse events when deciding for a restrictive strategy for red blood cell transfusion. So to conclude, I think our current approach to oxygen delivery optimization is mainly based on stroke volume manipulation, and we do that according to Frank-Starling principles. This approach is mainly a physiology-based approach, and probably we don't have robust data on the impact on survival. But we do have robust data on the of using fluid-responsive tools if our aim is to manipulate stroke volume. And we also have pretty robust data on being restrictive with red blood cell transfusions. So my last thought is probably we do much or less good, but manipulating oxygen transport. But probably the main question with oxygen transport is what's the trigger for that and when to stop manipulating oxygen transport. So I look forward to the endpoints talk of resuscitation. And I thank you so much for your attention.
Thank you. Time for question. So when you introduce the inotrope, it's you tell us that it's based on the absence of response during a fluid challenge.
The absence of, sorry?
The response
okay.
in terms of cardiac output after fluid challenge. But I remember some study where we kill patients by trying to push the delivery. So do you think that, do you integrate echography in your strategy just to be sure that you really have to face to a cardiac failure? Could you comment on this?
Probably, I think we can do better, not only integrating maybe echography, but better deciding whether the patient needs or not to keep pushing his heart. So I think I've seen a lot of patients with high SCVO2 but elevated lactate, and because of the high lactate, giving dobutamine or a bad echo, giving dobutamine, and maybe that's not the problem anymore. You have a high SCVO2, maybe the patient has a problem in extraction, not in oxygen transport. So I think that might be a problem using only echo, but if you have low SCVO2 and high lactate, and you can use echo just to assess how the heart is doing, but probably independently of how the heart is doing, if he's not fluid responsive, probably you will try to use an inotrope.
Just one general comment on all the studies you included, and especially, I mean, you discussed the low versus high threshold of hemoglobin. I'm not so sure that these were studies where the patients were in shock as defined by all the speakers before, meaning, as Jack mentioned, with the impaired tissue perfusion, as Jan disclosed by the increased lactate levels associated with impaired tissue perfusion. I'm afraid that most of these patients had somewhat some lactate levels or use of vasopressors, and then you randomize patients after some time to receive hemoglobin or not. So are these really the candidates we discussed when we discussed to push the oxygen delivery?
Yeah, I agree with that thought, but probably we don't have the data of a really complex study integrating every single parameter of dynamic indices of fluid responsiveness, and if SCVO2 is still low or the heart is not doing well, what do you choose, the inotropes or red blood cell transfusion? I think we don't have robust data on which one to choose. Probably you will go for the, if you have a safe threshold of hemoglobin and nothing is wrong, you will try to aim for a dobutamine or inotrope test. And if it doesn't work, maybe you can try with hemoglobin. But again, I think the most important here is the trigger. What makes you decide that the patient needs still oxygen optimization? SCVO2 plus lactate, or SCVO2 plus lactate plus delta PCO2? I think that's a big question here.
Okay, so we admit that you need to have a trigger. The question is, when you have the trigger, you try to have your different steps.
Yep.
Fluids, at some point you are stuck because fluids in isolation cannot do anymore. The butamine or whatever other agent, yes, but if you have already an elevated stroke volume or a dynamic heart, maybe it doesn't help. And then the ultimate aspect begins to be hemoglobin. And so do we have, and I raise a question for Jan or for Jacques or for others, do we have, or maybe yourself, I mean, because you also use the near-infrared spectroscopy and others, do we have data that indeed tissue oxygenation may be helped by transfusion? I think that Jacques did a meta-analysis on this.
Well,
maybe
probably
you can
if Channing is here, probably he will say that the capillary hematocrit is important. But I think we don't have enough data to recommend that based on the microcirculation hematocrit.
But maybe if a microphone can come to Jack, the guy is there, he can comment because he has done a meta-analysis on different trials on what is the impact on oxygen delivery, oxygen consumption, and other aspects there.
It works. Excellent, thank you. So this is a very complicated question, clearly, Daniel, and you're right. When we see the studies that have been performed, it's in stabilized patient, and it's patient in the ICU needing subject for a transfusion, not a patient in shock. What we know, and you have participated to that, is that when we have some degree of microcirculatory alteration, when it's really bad microcirculation, probably giving some red blood cells, you can improve tissue perfusion and you can improve the microcirculation. You have shown that 10 years ago. It has been repeated with the infrared spectroscopy and blah, blah. But again, physiologically, I have sometimes some difficulty to understand the effect of transfusion on capillary perfusion, because we know that you can change the systemic hematocrit. The impact on changing the capillary hematocrit is very low. So, and finally, to complicate more the question we have discussed yesterday during an IS session, the difference between perfusion, fluid perfusion, and the amount of red blood cells on the capillaries. You can decrease delta PCO2 by just infuse, but if you have no red blood cells in the capillaries, you have no oxygenation of the tissue. So it's very, very, very complicated. And I think that we do not have robust data to advocate this.
So thank you very much.
Thank you so much.
So it's my pleasure to call Marc Leone from Marseille to discuss refractory septic shock. What is exactly a refractory septic shock?
Dr. Chairman, ladies and gentlemen, so I don't have the response to make it clear. So my conflict of interest. And so the rationale of this talk, what is refractory septic shock? What does it mean? So I will try to define refractory. I will try to define septic shock. It's pretty easy. And we will see how to intensivist approach refractory septic shock using a recent survey we did. And all this is quite important for future guidelines, for new drugs, for new therapeutics, because there is at least 20 different definitions in the literature, and now we need a consensus on this term. So, what is refractory? That's the definition in the dictionary. The first one in resisting control or authority. Basically, it's French, like Jacques. The second point is resistant to treatment or cure, unresponsive to stimuli, immune and susceptible. And I think that's the definition for us today. And the third definition is difficult to fuse, to corrode, or to draw out. But I will keep the point 2 as definition for refractory septic shock. What is septic shock? Is a suspected infection with a SOFA score above 2 or an increase by 2 points of SOFA score, and that's a sepsis 3.0, plus a lactate above 2, and the need for norepinephrine after an adequate, and I don't know what is adequate, an adequate fluid resuscitation. And that is the definition of septic shock. So a refractory septic shock is a septic shock unresponsive to treatment, in fact. So there is no consensual definition about the refractory septic shock in adults, but our colleagues from pediatrics made the job. And they very well made this job, and the consensus is wonderful. That was published in Healthcare Medicine. They provided 4 clinical cases of septic shock patients, children, with varying level of shock and organ dysfunction, and that was very pragmatic cases. And they obtained the response by 14 pediatric intensivists, and they use two-run Delphi survey. You all know what is Delphi survey. People, each participant can vote, and you have an agreement after. After that, they produce a validation cohort with 6 centers with 24 patients. And in this cohort, the mortality rate was around 11%. You all know that the mortality rate in children is lower than in adults. So they obtain what they call a draft definition. And the draft definition, and I like this, is blood lactate above 8 or an increase by 1 millimole per liter of lactate after 6 hours of resuscitation. Second point is the need for vaso-inotrope dependency, and they generate a score because they use norepinephrine, but also epinephrine, dopamine. So they made a score which is quite complicated, but that's very useful. And they make, and you have the dosage here. And third point, and that's important, I think, is a myocardial dysfunction. And they define the myocardial dysfunction like a resuscitation responsive, of course, cardiac arrest in PQ, or cardiac response finding with a low left ventricular ejection fraction or low cardiac index. And that was the draft definition that they made after the Delphi process. And finally, they obtain this definition. They obtain a computed definition, which is 1.01 the dosage of vasopressor plus 1.1 the dosage of lactate plus 18 if there was a myocardial dysfunction. And they obtain also a bedside definition on 5 points with the dosage of vasopressor, 1 point, the arterial lactate dosage above 8, 1 point, and the myocardial dysfunction, 3 points. And then they use a validation cohort. And in this validation cohort, you can see that I didn't write the area under the curve, but that's very good definition with a cutoff at 2 for the bedside definition. And you see there is a very good discrimination. So this process is interesting, and we can replicate this process in an adult population. So I try to do that by myself, just an example that we can do, okay? So I use a survey we did with a group of friends with ISICEM. That was an online survey. This is a big survey, but I only use two questions. We received 820 response from 78 countries, and 80% of respondents were active intensivists. Most of the respondents were from Brazil, France, and the US. So that's quite representative of what happened in ICU in the world. And a surrogate for me for defining the refractory septic shock could be when do you introduce a second vasopressive agent. And most respondents use the response at 0.5 microgram kilogram minute. And you can see that there is very low number using a second agent at 0.2, which is a definition, for example, in the paper on vasopressin. That can be the definition. Okay. Is it a right dose, or is it fine to introduce a second vasopressor for this dosage? But that's consistent what we publish and what other groups publish. You can see we have on this axis the percentage of deaths, and here the dosage of norepinephrine. And when you are at 0.5, you have a mortality rate around 50%, which is quite high. And if you try to expect 1 microgram kilo minutes, you have a mortality around 80%. And this was confirmed by the group of Bruno Levy. We published also the same kind of study showing that the cutoff at 0.75 with a mortality rate very, very high, 86%. So perhaps 0.5 is a reasonable goal. There is some limitations. First, most of respondents use MAP as target of treatment, and personally I don't think that MAP was a good target for treatment. I prefer lactate or other thing, but I don't think that MAP was a very good response, but that was the response. Most of respondents didn't know if that was base or tartrate norepinephrine. They didn't know the dilution they use in their unit. So there is some uncertainties that we need to progress. As the pediatrician told us that the myocardial dysfunction should be included in the definition, I use this response to the survey, what was the indication for inotropes by our respondents. And the first response is a low cardiac output using ultrasound. So I'm pretty sad with this response, but that was a single response possible. But perhaps I would like to use also increased lactate or low SCVO2, or we prefer low cardiac output thermodilution, but we can discuss about that, but I really think that we cannot use echo alone, like previously Antoine told us. So the survey summary is we use a second vasopressor when norepinephrine is above 0.5, and we use dobutamine based on a low cardiac output based on ultrasound imaging. So we can think what are the relevant endpoints, in fact, to define this and perhaps the dosage of norepinephrine is not the better endpoint. So I use this study. We did this study that was a study on the delta PCO2 in patients with septic shock. We published 2 years ago, and I used, that was a multicentric study, and I used this database with Romain Ronflet and Alexandre Serreuil to determine 3 phenotypes of patients: the safe, the intermediate, and the poor. The safe are very good low lactate level, good PCO2 gap, etc., etc. The intermediate are intermediate, and the poor are very high lactate level, etc., etc. So we have the database with 119 patients. And as expected, we have the patient safe with very low mortality, the patient poor with very high mortality. And we focus on the intermediate to know their trajectory, if they improve or they decrease their state. And we conducted this analysis, our statistician conducted this analysis, and we see that the first and the main important point was the dosage of norepinephrine, and the magic number was 0.4. That's not based on magic numbers. That was statistically the finding of the statistician. Second step, lactate level with a cutoff at 3.4. And third step, the delta PCO2 with a cutoff at 6. So with these 3 variables, we can determine the patient with poor outcome as compared with the patient with good outcome. So the phenotype analysis shows that the outcome determinants for the day 28 mortality was norepinephrine dosage at T0 and T6, serum lactate at T0 and T6. For clinical worsening, which was a decrease of an increase of SOFA score at day 1, that was norepinephrine dosage at T0 and T6, and the delta PCO2 at T0 and T6. So finally, if we look at that in the perspective to define refractory shock, we can say that a patient with norepinephrine above 0.4, serum lactate above 3.5, and PCO2 gap above 6 are the criteria for a refractory septic shock. So my take-home message, very simple. There is a need for consensus in adults we can use the same methodology that was used by the pediatrician, because I think it's very good. And the definition cannot rely on a single variable, but I propose, for example, these 3 variables: the dosage of NE, the level of lactate, and the PCO2 gap. And this is really need for future guidelines to know when we need to introduce a second vasopressor or second inotrope for our protocols and for the approval of new drugs in septic shock. Thank you for your attention.
Thank you very much, Marc. I think that in the definitions of refractory shock, we understand very well the poor and good evolution difference. But this perhaps does not mean that this would be the time to introduce the second agent. I mean, some people may advocate that even at lower doses of norepinephrine, you may benefit from some adjunctive receptor modulation, and or that the risk associated with the second agent will be even too high, so that I prefer to continue with some patients even with higher doses of norepinephrine than 0.4. So I think that
I agree.
usefulness.
That's just a red flag. You go in the wrong direction. My patient goes in the wrong direction, and I need to change something. Perhaps, very often, I agree, we have to decrease the norepinephrine dose, for example. But that's a red flag. The patient is unresponsive to the current treatment, change something. And I think we need this definition.
Oh, for sure. And the good aspect of this definition is that it's not based solely on the norepinephrine dosage. It's also taking into account perfusion indices and or even cardiac function indices if we go a little bit further. So I think this is really food for thought, and I think that I hope that in some future we will come with some more data taking these kind of indices into account. So any other comment or question? No?
So just, Marc, could you, with this definition, have you an idea of the mortality of this patient?
In our cohort,
yes,
that was around 35%, I think. 35%, and in the pediatric cohort, that was 11%.
Okay.
At day 28, okay?
Thanks a lot. So the last speaker, not the Jan Baker, will talk about endpoints of resuscitation.
So, and you have the music to go with you? So
Exactly. It will be a swinging presentation. So, endpoints of resuscitation. I tried to mix it all together. You will see some repetition from the previous slides I showed earlier. No conflict of interest. As I showed before, when we studied when to stop septic shock resuscitation, and when we looked at the normalization of these parameters, we found that both delta PCO2, so the veno-arterial CO2 difference, and the capillary refill time both had the same rapid restoration, normalization, when lactate was rapidly normalizing in the early phase. So that already shows that these parameters might add to, let's say, your resuscitation strategy in septic shock patients. And we also showed in another study that hypoperfusion parameters in combination with lactate tell you more, and that there is a limitation of using lactate as a perfusion parameter more than 6 to 8 hours after admission. And that capillary refill time, a normal capillary refill time basically eliminates the value of lactate as a perfusion parameter. And that even if you try or if you still resuscitate a patient with normal capillary refill time, just because the lactate is not responding, it might already be at 2 hours. That's a little bit disturbing, to be honest. But from this subgroup analysis from the Andromeda study, we clearly found that it might be even harmful if you resuscitate a patient with basically normal perfusion parameters. And this is the study that I alluded to. If you add context to lactate and you create a hypoperfusion context to lactate, that should, let's say, stimulate you to target the perfusion as well. This is what we found. Not all differences are statistically significant, but if you have hypoperfusion and lactate, you need more norepinephrine to maintain your blood pressure. More high-volume hemofiltration was used as a rescue therapy, and that's, let's say, in addition to what Mark just presented, when at the point that you think this is refractory shock, the patient is not responding anymore, what we do in Santiago in Chile is high-volume hemofiltration, and so this is basically an indicator that the patient was not responding anymore. A higher mortality but no p-value, and a trend to somewhat more morbidity parameters that might benefit. So patients with hyperlactatemia plus a low SCVO2 or a high delta PCO2 or an abnormal capillary refill time, they have more severe circulatory dysfunction. Now, in other studies, we show that improving capillary refill time in following the initial fluid resuscitation in the emergency room is associated with improved survival. So if you have a patient in the emergency room, lactate, sepsis, you give fluids, capillary refill time normalizes, the mortality of that group is around 8%. If they don't normalize their capillary refill time, their mortality is around 50%. And so a clear indicator that a rapid correction of your hypoperfusion parameter, just as simple as capillary refill time, can already, let's say, select a group of patients that are very different than the other group. And so the responders is probably a very different phenotype than the non-responder. Oh, sorry. Limiting fluid resuscitation in patients. That's what we did in Rotterdam with one of my PhD students. We said, okay, if you take it all together, if there is no peripheral, if there are no indicators of hypoperfusion, why should you resuscitate? What's the point? What are you trying to do with your fluid resuscitation? And so what we said, if there is no hypoperfusion, you're not allowed to give fluids. You can do other stuff, you can give dobutamine, you can increase the norepinephrine, but you're not allowed to give fluids. Basically, you're not allowed to give fluids to try to improve cardiac output. And in that very limited study, only 30 patients, we showed that this strategy seemed to be safe, and that the strategy was associated with a decrease in SOFA, whereas in the control group, the control 15 patients, there was rather an increase in SOFA. And in a study that we did with the group in Austria for Martin Dunzer, we showed that the longer your capillary refill time, the more likely your abdominal organs like the liver, the kidney, the spleen, and also the gut are hypoperfused. And it seems to be a linear relationship up until a capillary refill time of 8. And that indicates that this capillary refill time is indeed an indicator not only of skin hypoperfusion, but could also be a marker of vital organ perfusion. And then we understand why you die if you have abnormal capillary refill time. Because if all these organs are hypoperfused, that's probably not good for your chances of survival. In the consensus statement that we produced already 7 years ago, we said, well, in addition to lactate and blood pressure and urine output, we think that measurements of SCVO2, so central venous oxygen saturation, and the delta PCO2 venous, central venous, minus the arterial PCO2 might help to assess the underlying pattern. In other words, to assess whether hypoperfusion is a real problem at that point in your patient. The level of evidence was moderate, and the recommendation was low. Now, delta PCO2 is something that I did when I was in Brussels. And we studied and together with Mark Leon, so we have a long history together. We studied the effect of delta PCO2 and cardiac output. And we plotted delta PCO2 and here cardiac index, and you see it's not a linear relationship, it's a curved linear relationship. But if you look at changes in delta PCO2 in septic shock patients and characteristics, then if your delta PCO2 is increased more than 6, and you compare it to a patient with a normal delta PCO2 less than 6, then the patient with normal delta PCO2 have a higher cardiac output, a higher SVO2. This is central venous, mixed venous, sorry, with a PA catheter, and a lower lactate level. And if you look at changes, then patients that improve their cardiac output, that decrease their cardiac output, increase their delta PCO2 during treatment. If they increase their cardiac output with treatment, then they drop their delta PCO2. So the delta PCO2 has some relevance as a perfusion parameter in the early phase of septic shock resuscitation. Gustavo Ospina studied this into somewhat more detailed. He looked at the differences at different times. So initiation of the study, 6 hours later and 12 hours later. And he looked at patients with a high delta PCO2 and patients with a low delta PCO2. So normal perfusion, abnormal perfusion, and he looked at the changes in lactate. And as you might expect in the early phase, patients with a normal delta PCO2, so normal flow, decreased their lactate much faster, much more significantly, 20 to 40%, whereas the hypoperfused have much lower or hardly any clearance or change in lactate levels. And this was associated with mortality as well. So if you put this all together, and so we have all these perfusion parameters, then how should you target the patient with an increased lactate? And I think we all agree that the patient with circulatory shock needs to have an increased lactate. It's weird to have shock without lactate. So we have the patient with an increased lactate. The first thing you have to do is create context, as I said in my last presentation. So the first question you have to ask yourself, is there a likelihood that there is another source, an aerobic source, a metabolic source, metformin, an intoxication with CO, diabetic ketoacidosis, thiamine deficiency? I mean, there are so many reasons why you could have an increased lactate, but not being in circulatory failure. If your answer is yes, then of course treat it accordingly. Do something different than the reflex of a liter of saline. If the answer is no, I think that this lactate has something to do with the circulatory condition of this patient, then the next question you ask yourself is, what's the peripheral perfusion? And if you have a central venous catheter, and this is ICU-based, not emergency department, so you should have an SCVO2 in these patients. If there is normal peripheral perfusion, then measure the SCVO2. So the patient is warm, you have lactate, you think there's something wrong with the circulation, measure an SCVO2. If the SCVO2 is normal, then measure the delta PCO2, because we know from the study from Gustavo Ospina that you can have a normal SCVO2 and an abnormal delta PCO2. So if everything is normal, then use your last perfusion parameter, the delta PCO2. If that one is also normal, so you have an increased lactate, and all your perfusion parameters are normal, then you have to rethink what's going on here. Did I make a mistake? Did I miss something? Go to the family. If the patient can answer a question, go to the patient and ask and discuss. And so make sure that there is nothing else that's intervening with your lactate production. If the delta PCO2 is abnormal, so all of this is normal, but your delta PCO2 is abnormal, then increase flow. So restore cardiac output, increase cardiac output, delta PCO2 should fall, and lactate should decrease. That's what you would expect if the lactate is an element of tissue hypoperfusion. If it doesn't happen, there's no change in lactate whatsoever, you have to rethink again, because now you get all these signals like there is no hypoperfusion. I still have lactate. Is lactate still a problem in this patient? Is it still reflecting what I think is tissue hypoperfusion? Most likely not, but you have to ask the question yourself. If there is no other cause than what you think is a circulatory problem and your peripheral circulation is abnormal, so your capillary refill time is increased, the patient is cold, the patient has a mottling score, all these indicators of peripheral perfusion, or you have a low SCVO2 just because you already have a catheter, then you have abnormal flow and you correct it. You either use fluids, you use dobutamine, you use milrinone, whatever your protocol is or your way of treating patients with hypoperfusion is. And if you correct the SCVO2 and peripheral perfusion, lactate should fall. If it doesn't, if it does, then wait and see. You have your perfusion parameters normalized, and then you wait and see, because lactate clearance in individual patients is very different. Some clear rapidly and others take much longer. So observe what's happening to the lactate. If you normalize the flow but lactate doesn't change, then measure your delta PCO2 again. So peripheral perfusion is okay, your SCVO2 is corrected, measure the delta PCO2. If the delta PCO2 has also normalized, you come back again to, is there another source? If your delta PCO2 is abnormal, then do exactly the same. You already increased flow, but not enough. And so you increase flow even more than you already did here, and lactate should fall again. And then you observe. And of course, if it doesn't happen, rethink again. So rethink during your resuscitation constantly whether lactate is really an indicator of perfusion and nothing else is going on. And this is the full protocol that we published in the 10 pitfalls of lactate. So in conclusion, if you want to optimally resuscitate your patient, you need a holistic view. You do not restore the cardiac output, or you do not restore the mean arterial pressure and go and have a coffee or go for lunch. That's not how you resuscitate a patient in circulatory shock. What you do is you optimize the perfusion of the vital organs, and you use every parameter that you can think of to check whether you did it adequately. And if you have corrected your, let's say, tissue perfusion-based parameters, I think you're done. And I'm not going to talk about mean arterial pressure because that was another topic. So it's a holistic approach of your patient using every perfusion parameter that you can use. Thank you very much.
Thank you, Jan. Is there a question? So you start with lactate in your algorithm, but do you think that now we have to start with the capillary refill time?
No, because capillary refill time is not an indicator of a problem. And of course you need a problem. And I think, to be honest, lactate is a more, let's say, a valuable indicator of trouble than abnormal capillary refill time. And I think my capillary refill time now is, I'm a little bit excited, it's not completely normal. And that's just because you're not agitated, but your let's say, your sympathetic nervous system is increased, and so your capillary refill time goes down. And so I think capillary refill time as an indicator, let's do something, is not that okay. And as I said in the lactate lecture, you can have abnormal capillary refill time and be perfectly healthy. You don't walk around with an abnormal lactate level. So I think as an indicator, I need to think and do something, maybe do something. It's better than capillary refill time.
And if we may add something on this, I mean, in the Andromeda trial, the inclusion criteria was to have an elevated lactate level.
Yeah.
So the trial did not test resuscitation based on CRT in patients with abnormal CRT and normal lactate. So sometimes people make some misunderstandings there, but I think it's very important you precise this, that indeed you need to have the lactate elevated to begin with.
Absolutely.
Thank you. I want to thank again all the speakers for their great lecture, and have a nice evening, and see you tomorrow.